Hello, myself Keerthika, tutor cum physician assistant in Yenepoya School of Allied Health Science. Now we are going to see about pyelonephritis. So the specific learning objectives are at the end of this session, student should able to know the risk factors and causative organism of pyelonephritis, pathophysiology of pyelonephritis, management of pyelonephritis, and how to approach patient with pyelonephritis. So from that name we'll know about this. What is acute pyelonephritis? Acute means it develops quickly. Pyelo means renal pelvis. Nephro means kidney. Itis means inflammation. Okay, this is the inflammation of the kidney that develops quickly. So what is the definition? It is a bacterial infection of the renal pelvis, tubules and interstitial tissue of one or both kidneys. So usually the upper part of the urinary system is kidney and ureter, and the lower part is bladder and the urethra. So this acute pyelonephritis will develop in upper urinary tract, also in lower urinary tract. It is usually bacterial infection. It is the ascending infection causes lower urinary tract infection, spreads into the bloodstream, called as a hematogenous infection. This will lead to septicemia, infective endocarditis. So the causative organism for the septicemia and infective endocarditis is Staphylococcus and E. coli. So what are the risk factors? Coming to the mechanical, VUR, that is vesico-ureteroflex calculi, pregnancy, neurological bladder or urinary tract obstruction, benign prostatic hypertrophy, bladder tumor, urethral stricture and indwelling catheter. So coming to the constitutional risk factors, it is diabetes mellitus and immunocompromised states. So what is vesico-ureteroflex? So in that infection will spread upper to lower. So failure of vesico-ureter orifice. So in some conditions this urine will backflow to the kidney. So what are they? Primary congenital effect, bladder outlet obstruction. So this bladder outlet obstruction is due to increased pressure that urine will remain in that bladder. So because of this urinary stasis, there is a lot of chance to grow bacteria. So what are all the causative organisms? Most common organism is Escherichia coli, Klebsiella pneumonia, Pseudomonas aeruginosa, Proteus mirabilis, Enterobacter species, Enterococci species and Citrobacter species. So coming to the pathophysiology, acute pyelonephritis is most often unilateral, but it can be a bilateral also. It is characterized by extensive acute inflammation involving the interstitium and causing destruction of the renal tubules. glomeruli and renal blood vessels show considerable resistance to infection and are spared. Abscess on the capsule and at corticomedullary junctions. When it's chronic, kidneys became scarred, contracted and non-functioning. So what are the clinical features? So the first one is chills and rigor, fever, loin pain, lumbar tenderness, dysuria, frequency of maturation, nausea and vomiting. So what are all the diagnoses? First one is urine analysis and CBC, urine culture, blood culture, USG abdomen, CT and all. So in this urine analysis, abundance of bacteria, pus cells and pus cast will be there. In CBC and all, leukocytosis will be there, that is increased WBC count. So we'll send urine culture to identify the organisms and drug sensitivity, and blood culture to identify the hematogenous infections, and USG abdomen is to know about hydroerythronephrosis. So what are all the management? Hydration, antibiotics and surgical intervention, that is DJ stenting, double J stenting. So what are all the complications? The first one is papillary necrosis, pyelonephrosis and perinephric abscess. So what is chronic pyelonephritis? It is a chronic tubulointerstitial disease resulting from repeated attacks of inflammation and scarring. So initial in this acute, there is mild moderation, and this chronic lot of scar will be there, and that kidney will contract. So how to approach a patient with pyelonephritis? A patient present with signs and symptoms suggestive of pyelonephritis, first you just assess about A, B, C, D, E, that is airway, breathing, circulation and all. If that patient is unstable, you should do acute management. First you should stabilize the airway, breathing and circulation, obtain IV access, supplemental O2, and you should monitor vital signs. If that patient is stable, focused on history and physical examination. And history taking, just ask about fever, chills, malaise, flank pain, nausea and vomiting, and about dysuria. And physical examination, just assess about flank tenderness, abdominal tenderness. If you are suspecting pyelonephritis, send the lab investigations like CBC, CMP, urine analysis and urine culture. So in the CBC, you will know about some leukocytosis, and CMP elevated BUN or elevated creatinine level. In urine analysis, pyuria, bacteriuria will be there or hematuria will be there, leukocyte esterase, nitrates and WBC cast will be there. So this is the acute pyelonephritis. So now you assess the need for hospitalization. If that is a outpatient management, first you have to assess they will tolerate oral intake, able to adhere to treatment, no coexisting conditions like DM and all. So if you can manage with OP, start empiric medical therapy, peroral hydration, antibiotics, that is parenteral, 1 dose, then start with peroral. IM cephalosporin, example ceftriaxone, and start peroral fluoroquinolone, example is ciprofloxacin. So if that patient requiring hospitalization, so what are all the inpatient management, failed outpatient treatment, who and all cannot tolerate oral intake, consents for non-adherence, coexisting conditions. So you have to start empirical medical therapy, IV hydration, IV antibiotics such as ceftriaxone or piperacillin tazobactam. So tailor antibiotics based on culture results, then assess their response. If the dose is adequate, that is uncomplicated pyelonephritis, patient will recover, complete the current antibiotics. If that is inadequate, suspect complicated pyelonephritis. So they will need inpatient management. So in inpatient management, you just assess about assess the response. Okay, adequate complete treatment as an outpatient, transition to oral antibiotics, and if that is inadequate, you just do imaging like ultrasonography and CT. If that is normal findings, that is uncomplicated pyelonephritis, then according to Taylor, you can antibiotics based on culture results. If is there any obstruction, anatomic abnormality or abscess is there, means that is complicated pyelonephritis, can tailor antibiotics based on culture results, and you can obtain opinion from the surgical department. So if that is uncomplicated, assess the response, adequate, complete the antibiotics. If it is inadequate, repeat the urine culture and repeat the imaging test and consider surgical consultation. So to summarize, definition, risk factors and causative organisms for acute pyelonephritis, and pathophysiology of pyelonephritis, diagnosis and management of pyelonephritis, and how to approach patient with pyelonephritis. Thank you.